Okay. Good afternoon, everybody. My name is Kathy Yao. I am chair of NAPBC, and we will be talking about the prompt study today. Okay, I can't advance the slides. ASA won't let me advance my slides. I don't know why. Oh, there we go. Okay. So here's an outline of what we'll be talking about today. I'm going to present some of the feedback survey that you all generously filled out. Just a note about the 2022 data. I know that some sites submitted this data. We are working on putting that together and getting it back to you. I'm hoping in the next few weeks we'll be delivering that back to you. And then I'm going to be talking a little bit about what sort of documentation is required to show that you participated in prompt for 2022 and 2023 for the site reviews that are coming up. And then we will end with a presentation by Dr. Shelton, who is going to talk about his prompt experience, and he is at the Outer Banks Hospital in North Carolina. First, just some stats and deadlines. For 2022 data, we had 67 sites submit data. That deadline has passed, as you all know. We had 104 sites submit the feedback survey. As you know, I did not require that. That was purely voluntarily submitted, and the deadline for that has passed. And the prompt QI template, which will document your participation in the QI aspect of prompt for 2023, that will be due January 15th, 2024. And so far, we have about 98 sites that have submitted their templates. Let's go to the feedback survey. I didn't include every single question from the feedback survey, but tried to include the important ones just for your information. So will you finish prompt by the end of the year? 67% of sites said yes, 30% were not sure. And just to remember, and I do mention this later, that if you extend your prompt study into 2024, that's perfectly fine. You won't get credit for 2024, but you can certainly extend your study into 2024 to complete it. Which prompt timeliness metric are you working on? We can see a fairly even distribution between screening mammogram and diagnostic mammogram, diagnostic to biopsy, and biopsy to surgery. And probably a little less sites are working on the biopsy to neoadjuvant therapy. And then where are you in your template in terms of the ACS quality framework? It looks like the majority of sites, about 40% or so, are in the process evaluation step. Was a year enough time to submit all your timeliness metrics? 82% of sites said yes. And was 1 year enough time to do your prompt QI project? A little bit lower percentage of sites, about 64% said yes, 20% or so checked not sure, and obviously some said no. So we can see that, and this is what I've realized, that these QI projects do take time. Sometimes a year is just not enough time. Right now, we are still requiring 2 QI projects according to the 2018 standards. As we move into 2024 standards, we will only be requiring 1 QI project. How helpful were the following? The pre-recorded webinars that I put together to walk you through the ACS quality framework. Roughly 80% or so said somewhat or very helpful. The QI template, somewhat helpful, 33%, very helpful, 50%. And then the monthly webinars, somewhat helpful, 38%, very helpful, 46%. So, I mean, for the most part, most of these things were somewhat or very helpful, but certainly probably some things that we can work on in the future to use your time more valuably. What about things that you would change about prompt? And I just picked out some comments that I saw multiple times. And talked a little bit about how we address these comments, or just comments that are good to know for future projects. Years of the study, you were all impacted by COVID. I completely agree. This is why we wanted to collect 2022 data for those sites that thought it would be useful for them. More clear inclusion-exclusion criteria noted. I agree, and that's very important to make that clear from the outset with these projects. Hard to control time delays with cases that are diagnosed on the outside. I've heard this from many sites. Makes me almost think that maybe we should have a future QI project just focusing on those patients that come from the outside, i.e. get their diagnosis from a different hospital or different center than your center, and then come see you, and how can you facilitate time to care for those patients. Talk about the prompt QI template from day one, and more info on how to complete each section, and those are great ideas. I completely agree. As you know, the prompt QI template is a little bit different than the steps that are outlined in the standard. The QI template takes you through the ACS quality framework, which is a new framework that the ACS has launched across all of their quality programs, not just cancer, bariatrics, trauma, etc. And if you look at publications about the ACS quality framework, it's quite detailed. And I did really dumb it down with the pre-recorded webinars and the steps that I'm taking you through this. But at some point, we will all be using this ACS quality framework, and I felt it was a good idea to get everybody up to speed on it. More discussion with other centers, I completely agree. A big part of these collaboratives, people talking with each other, learning from each other. This is part of the reason why we launched the Salesforce platform. Although we launched it late, we probably should have launched that much earlier in the project. And I am hoping to have a networking session in place at the ACS Cancer Conference in Austin, Texas, February 22nd to 24th. Expanded time frame to complete the study. As I mentioned, you can continue your study into 2024. It won't count, but if we're not going to penalize you if you continue it into 2024. You are allowed to start a brand new prompt study in 2024. It's got to be something different than what you did before. Different aim, different problem, different timely metrics, so forth and so on. So there is that ability if you would like to do that. Provide a toolbox or best practices. We are going to do that once everybody has completed their QI templates. We're going to aggregate all of the data and interventions, root causes, measures that people looked at, and we will be issuing a final report and a toolbox for centers to use to learn what other sites did to improve their timely metrics. Make it count for those with 2025 surveys. So those sites that are being site reviewed in 2025 will be site reviewed on 2024 activity according to 2024 standards. And as I mentioned, if you want to start a new prompt study as a QI study in 2024, you are allowed to do that. So you technically could do that. And more time to do the QI part. And I agree, these QI studies always take longer than you think they're going to take. And this is something we need to consider in the future with future QI collaboratives, that maybe it needs to be a longer time period for the quality improvement and maybe even a shorter time period for the data submission. All right. Next slide. So people really wanted to understand more about the interventions that sites were using in their QI studies. So I did ask on the survey to list some of the interventions you were working on. So I compiled those here. Again, these slides will all be available on the NAPBC portal. We can email all of these. We will make them available on our website and on the Salesforce platform, so you can refer to these in the future. But for screening mammogram to diagnostic mammogram, sites stated that they expanded staff. They took measures to reduce turnover in staff. They hired dedicated radiologists. They changed the schedule of the radiologist to open up more spots for diagnostics. Some sites employed a waitlist function, so if a patient couldn't get in for a diagnostic mammogram right away, they would be put on a wait list. And there is an ability to do that actually within Epic. That's what we did at my center. They changed the order set to allow auto default to diagnostic mammogram for those patients who had abnormal screening mammograms. And then one site stated they facilitated the ordering process for PCPs to get a diagnostic mammogram ordered. Let's go to the next timely metric diagnostic mammogram to biopsy. So here's a list of things that people did for their interventions. They changed their anticoagulation protocol. I thought that was very interesting. Added staff. You're going to see that's a common theme through all of these interventions is staff. And I know we are all struggling to find staff, recruit staff, retain staff, but you will see that that is a consistent theme throughout all of these interventions. They partnered with a local surgeon. They hired a breast imaging navigator. They hired a breast dedicated radiologist. They changed the scheduling process for biopsies, blocked some time, added a double procedure day weekly. They enabled a direct referral from the radiologist to the surgeon. They offered biopsies at other different locations. And then they actually conducted a patient survey to get the patient perspective on this time interval to see what they could do to improve it. Biopsy to surgery. Several sites stated that they hired more surgeons. They hired a navigator. They are working with more than one plastic surgeon. I know that getting into plastics can be a challenge, and then getting those cases on the OR schedule can be a bigger challenge. Worked with cardiology to streamline the pre-op clearance process. Patients see plastics and the breast surgeon at the same time. They worked on standard criteria for ordering an MRI. I know at my institution, getting an MRI is taking weeks, and so we have talked about that as well. Getting more OR block time for surgeons and for the plastic surgeons. Established an institutional timely standard for getting MRIs ordered. Shifting more follow-up patients to an APP to free up the surgeon's schedule so that surgeons can see patients sooner. Genetic panels, that's another definitely potential for delays. And this one center set it up as a stat panel. And offering an initial virtual visit with the plastic surgeon to at least get the ball rolling, and then eventually a plastic surgeon would see them in person, but at least that initial consult could get things going and possibly work on an earlier OR date. And then finally, biopsy to neoadjuvant therapy, having the surgeons order the staging studies, labs, getting even a portacath set up. Some surgeons place ports, some don't. Prioritizing port placement for breast cancer patients in interventional radiology. I know at my site, getting a port has been a big challenge. The interventional radiologists are just completely overwhelmed with all of their procedures that we've had a really hard time getting the ports placed. Streamlining the process to determine social determinants of health and how those are impacting getting patients in to start neoadjuvant therapy. Streamlining ordering the echo to get patients prepared for chemo. Placing the ports ASAP, even before seeing the medical oncologist, and working with the pathologist to streamline the process for sending pathology slides for review. So hopefully some of these interventions will be helpful to all of you. And again, this will all be available, and this is all going to be part of the toolkit that we will assemble next year. So let's go through a little bit about the documentation that's required to show that you participated in PROMPT. And just to remind everybody, PROMPT counted for year 2022 and year 2023. In year 2022, it counted for standard 6.1 as a specialty specific QI study. As you recall, 6.1 requires 2 QI studies. They can be internal or specialty specific, and PROMPT would count as a specialty specific. In year 2022, PROMPT also counts for standard 3.2 clinical trial accrual. Sites still have to review with the site reviewer what they're doing with other clinical trials, but as long as you participate in PROMPT, you will get credit for 3.2. In year 2023, PROMPT will count for 6.1 as a center-specific QI study because you're working on quality improvement at your site. PROMPT does not count towards standard 3.2 in year 2023. And PROMPT, remember, only counts towards NAPBC standards. It does not count towards COC or NAP-ERC. What kind of documentation is required? So for year 2022, remember, you will get credit for standard 3.2 and 6.1. there was an email that was sent to your site documenting that you participated in year 2022, you submitted your data, so you would upload that email into the PRQ. This is what the email looks like. It came from brp@northshore.org, and it states that you will receive credit for the following standards. You participated, and as long as you upload this email into the PRQ, you will get official credit. If you can't find that email, have displaced it, you can email us at brp@northshore.org, and we can send it back to you so that you have that. For year 2023, you only receive credit for 6.1 as a center-specific QI project. You need to complete the prompt QI template. You need to fill in all of the steps. And you can print and save, actually you can download that prompt QI template as a PDF, and you can save it on your hard drive, and when your site review comes up, you can print that out and then upload that into the PRQ. I also would like all sites to present their findings at the BPLC meeting, so that should be documented in a BPLC minutes. And that's what the site reviewer will be looking for. They'll be looking for the prompt QI template uploaded into the PRQ, and also looking for documentation that the results were presented to the BPLC. So just to clarify here, once the prompt QI template, once you hit that submit button, you will see a screen that comes up that states that you can click on download PDF, and allow you to save it into a folder so that you have it for later for when you have your site review. And I have a picture here. So you hit that button submit, and then you will see this screen, say thank you for taking the survey. And there's a button download where you can download the PDF onto your hard drive, and later on you can print that up and upload it to the PRQ. NAPBC will allow you to conduct a separate prompt project as a QI project in 2024. Must be different than the previous one, and this would just count towards one of your QI projects required for 2024. Some future directions: we are developing a patient satisfaction with timeliness. We're in the validation phase right now. It's a survey of about 10 or 12 questions. And we're hoping that sites can use this to determine patient satisfaction with timely care. Dr. Tammy Stump, who's our PhD who conducted the qualitative interviews, is conducting what we call face validity with this patient satisfaction survey right now. She has given it to about 7 to 8 patients who underwent the qualitative interviews, and asking them if they understand the survey, is the wording correct, does it make sense, because we want to make sure that the questions are asking what we really want them to ask, and that the patients understand what we're asking. We are working on 2022 data, and we will be compiling that and giving that back to sites who submitted that data. As I mentioned, we will be putting together a toolkit for all of you that participated in prompts, so that you can go back and reference what other sites did. But that will not be available till next year, after we have all of the prompt QI templates to examine. And we are working on some manuscripts, which I did not mention here. We are working on one manuscript where we will outline all of the qualitative patient interviews and what patients said, describe the themes that we learned from patients. And then the second manuscript we're working on is the prompt timeliness metrics and how they're associated with certain facility factors. So we will be letting you know about those 2 manuscripts. And we will be having a session at the ACS Cancer Conference in Austin, Texas, February 22nd to 24th. I hope that you've all registered. I think there's the ability to register, or maybe Asa, you can correct me on that, but we are hoping to have good turnout at that meeting in February. That is all I have right now. And I think what we'll do is we'll go to Dr. Shelton's presentation and let him present, and then we can take questions at the very end. Our next webinar is going to be December 11th at 12 noon, same as this one. So let me close out of this slide presentation. And I will go into Dr. Shelton's presentation.
Hey, can you hear me okay?
Yes.
Hi, good
Hi.
afternoon. Hey, so thank you so much for the opportunity to talk today. I'm just going to present our small community hospital perspective on this collaborative and how it's changed our care locally. Next slide. So this is a slide that I think nicely shows our small footprint on an island, a barrier island in the middle of the Atlantic Ocean. So we're a young hospital that's only been open for about 2 decades. The majority of our patients receive some component of their care outside of the island and typically have to go to the mainland for some aspect of their care, which creates some issues, as you might imagine, with timeliness. Next slide, please. So we are a critical access hospital. We're probably one of the smallest hospitals within the NAPBC. We're a 19-bed hospital with a focus mainly on critical needs of the community. And for us, that was very quickly recognized as cancer, which is something we began to focus on, first with COC accreditation in 2016, and then we're only a year fresh from accreditation with NAPBC since 2022. So we were very excited to be part of this collaborative. So I'm not sure what Dr. Yao thought when she sort of postulated this programmatic goal, but these are kind of the hypotheses that I thought of. Where do we fit in as a small program? So timeliness to care is obviously important, and so as a rural program, we clearly have, or at least what we think of as timeliness concerns based on access issues. We are historically, in other words, not prompt. Timeliness for most of us, of course, was worse during COVID. We had the similar V-shaped curves that everyone saw with their screening during the peak times of COVID. And hopefully we've all returned to some normalcy since COVID has resolved. All programs, I think, can improve timeliness if we make it a common metric. We all tend to be very competitive, I think, in what we do. And so when we see ourselves ranked compared to other programs, I think this is a little extra incentive for us to do better. And we do, by the way, anticipate that we are lower in rank than most programs, being new, being small, having a lack of resources. As a large participant in a collaborative, I think we can also help establish standards. And I think that's probably one of the bigger issues with this, is we can look at what is expected to be a norm nationally and what should we all shoot for goals in these various timeliness metrics. And like a lot of programs, we only had guesstimates of where we thought we were. So why did we participate in this QI? Well, one, we're small. We don't have a lot of resources. We represent a very unique perspective. We have barriers to care that are primarily related to rural access concerns. We do expect timeliness was a concern for us. It was very appropriate for us to be focused in this collaborative to try to work on identifying these barriers and improving them. And again, we have limited resources. So where a lot of programs were able to hire extra personnel to help with planning the imaging process or the navigation process, we don't have that large amount of resources where we have to sort of reinvent what we're doing locally just to do better. And this may typify some of the other smaller programs as well. Next slide, please. So this is our data, and this is humbling, by the way, to look at. This is where we were with the 3 of the 4 metrics. I'll show you the 4th metric in a second, but these are metric 1, metric 2, and metric 4. So for screening to diagnostic, diagnostic to biopsy, and from time to treatment. We did poorly. So we were in the last quartile, I would say, for all of these metrics. And, you know, again, this is not terrible. If you look at how far we are away from the median, we are not far away, but certainly we do want to do better. This was during the peak COVID era. What I will say is for the first metric, we were 17.4 days, which put our rank at 241, again, bottom quartile. If you look at metric 2, we were 18.3 days, which was a rank of 279. And for the last, which I think is a compilation of the first two, of course, we were 51 days median time to surgery, which was a rank of 242. So this was clearly fuel for us to say, hey, okay, this is how we compare. This is perhaps where we need to focus on improvement. Next slide. Interestingly, when you look at the time to neoadjuvant therapy, we were an overperformer in this metric, and I'll get to why that is in a second. So we were the top decile for timeliness to institution of systemic therapy when neoadjuvant therapy was on first order. Next slide. So, preliminary data analysis for this looks like we do have a timeliness issue. Indeed, we are not as prompt as we could be. We did see a decline in COVID in 2020, and we did return to our pre-COVID baseline by 2021. We outperformed only in one measure, and that was neoadjuvant therapy. And I think that's a function of having a local med-onc provider to be able to pull the trigger quickly after our breast tumor board discussions and after the decision has been made for that to be the first therapy. This contrasts to surgery, where we do not have a local breast surgeon in our community, and the surgery part of all treatments has to be done outside of our community, or at least for the majority of our patients, has to be done in other cities outside of the Outer Banks. So we reset our goals for timeliness metrics based on other results from programs that we sort of have to compare ourselves to. We're probably not like a lot of other programs, but with this data, we felt we should reset some of our expectations. Next slide. So looking at root cause analysis for these four metrics. So for the first metric, we felt that radiology and the primary care provider were responsible for this metric mostly, the time between screening mammogram and diagnostic mammogram. So this was a function of our radiologists and our primary care locally. Again, not all imaging is done locally at our hospital, so that's a challenge. How do you move a metric when you don't have control of it? But we felt that we could improve perhaps the process of getting that information at the time of screening to the next step in the workflow, which would be either the radiologist or the primary care provider making that information available to the patient. The second metric, looking at timeliness to a biopsy is completely for us dependent on a surgeon. We do not have interventional radiology, so we have to have a surgeon in our community or outside of our community perform a biopsy once an image has been deemed diagnostically appropriate for a biopsy. So for us, that's done by a breast surgeon in over 90% of the cases. And so for us to change this metric, we felt we had to get patients to our breast surgeon sooner. In other words, at a more rapid pace to get a biopsy done more quickly. For the third metric, we didn't feel like we had a problem with the timeliness to neoadjuvant treatment, either chemotherapy or hormone therapy. Since we, again, have a full-time med-onc locally, we felt like we had already performed well on that metric, so we didn't feel that was something we wanted to improve upon. And for the last metric, the timeliness to overall care, primarily surgery, in the non-neoadjuvant setting is a compilation, of course, of the first several metrics, right? So if we do poorly in 1 and 2, we're going to obviously not do great in metric 4. And since we only have one breast surgeon present locally, and the majority of the surgery is done outside of our hospital, we felt that we had to figure out innovatively how do we move this last metric, or can we even move that metric? All right, so next slide. Areas of potential improvement we thought were there for metric 1, perhaps we could improve the screening time to diagnostic as a function of radiology, which we can control at our hospital. All that's in our wheelhouse, and we felt that was something perhaps we could move. For metric 2, the time to get the patient to the surgeon may be a little more difficult, but again, we thought that was within our wheelhouse because our surgeon is locally available and can access patients if we call him quickly, and we felt that that was something we could improve as well with this study. For metric 4, timeliness to surgery, what we thought was since a lot of our patients are having surgery at other hospitals, that is something we cannot control, but we can control the timeliness to surgery at our local hospital. And so one area of potential improvement would be perhaps to add a local slot on the OR schedule for a breast surgeon to be available at our hospital to perform these surgeries locally. We also looked at improving the coordination of care, what Dr. Yao alluded to, which is the validation survey from patients. We do what's called a patient-reported outcome sort of exit interview after therapy to see how the focus on timeliness as this project has impacted the patient's care, how it's impacted their understanding of the various roles of the different providers during their care. We thought that was a nice soft endpoint that we could look at as a quality initiative as well, where perhaps if we didn't meet metric 1 or metric 2, we would have something that we could show as an improvement in this study. And again, sort of the ultimate goal for us was not just to do better, but to show some improvement in our overall rank compared to other programs in these various metrics. So next slide, please. So our interventions are as follows. For metric 1, we reviewed our data with our staff and with our cancer committee, and we set goals, how long we thought it would be appropriate to go from imaging to diagnostic imaging. We thought that less than 2 weeks was appropriate for where we live and what we have available. We partnered for metric 2 with a local breast surgeon to discuss ways to improve the timeliness to get a tissue diagnosis after the abnormal imaging, to get perhaps quicker consults with the breast surgeon. And the office where he works typically is where biopsies are done. So we thought if that could be done within 2 weeks, that was a reasonable goal for us as well. For the third metric, even though we did well with neoadjuvant therapy, we did have a local med-onc who retired during this sort of post-COVID era in 2022, and we partnered with a new local medical oncologist to help continue that metric so we didn't fall behind in metric 3. And for the last metric, for time to surgery, we added a surgery block at our local hospital for a breast surgeon to help improve that particular metric. Next slide, please. So one of the really helpful interventions for us was to look at the use of the multidisciplinary conference, and this for us was huge. We typically present 100% of our newly diagnosed cancers at a multi-D conference before any therapy is done, and we do see a small number of cases, about 60 diagnostic or analytic cases per year. And what we began to do with this study is we represented patients at any pivotal point in their care. So not just at the initial onset of diagnosis, but perhaps after imaging, after further MRI imaging, if another biopsy was necessary. We kept presenting patients at various points during the multi-D conferences biweekly to help facilitate better coordinated care. We then tracked the timeliness in real time on a spreadsheet, looking at all of our local breast database, and then we would typically review this at meetings as well so that if any outliers were noted, we could intervene more quickly. Next slide. This just kind of shows you a visual representation of how we do our multi-D conferences here are basically presented over and over and over until the patient's journey is complete. So we'll find the first course of therapy, we present 95 to 100% of patients prospectively. Of course, patients who've already had a diagnosis outside our system who come here for adjuvant treatment after surgery would not be presented prospectively, but before their second course of therapy, they would be. So at every point that's pivotal in their care, we represent patients if it's going to impact something in their timeliness or something as a function of their outcome that we feel is important. Next slide. So these are our results from this year. So following the baseline data, we started data collection in 2023. We found that for the first metric, time to diagnostic imaging from the original screen, we achieved 14 days, which was a 1-day improvement over our baseline. And again, 14 days was our goal, so we met goal number 1. For the second metric, timeliness to biopsy from an abnormal image, we found 12 days, which was a significant improvement of 6 days over our baseline, which was even better than our goal of 14. For the third metric, surprisingly, even though we were already in the top decile before, we actually improved by another day. So our time to neoadjuvant is now 22 days, where our goal was less than 30. And then for time to primary surgery, we found that when we had patients receive all of their care locally at our hospital, our median time to surgery dropped to 47 days. Now, like a lot of programs, some of our patients do receive care outside of our system at other hospitals. And again, those are probably programs where we can't impact that timeliness measure. So we felt that this goal for us was achievable. And indeed, our goal was less than 60 days for most of our patients. And we were also looking to eliminate some of the outliers that we had seen previously in our baseline. And then the last quality improvement that we did was that soft sort of feedback mechanism from the patients to look at how we impacted the coordination of their care. And we found that this was very helpful, that patients expressed extreme satisfaction knowing where the various roles of all of the providers were in that journey through their care. Next slide. So I'm going to show you where we were at baseline, just to show you a couple things here. So this is pre-QI. This is the 3-year data for the study where we looked at how long did it take to go from the original mammogram to the surgery, or the original tissue diagnosis to the surgery for the timeliness metric. And if you look at where we were as a whole, go ahead and hit that next button, Kathy. We were about 70% of our patients were less than the 60-day desirable threshold. And again, we didn't know 60 days was what we were shooting for at that time, but we were doing okay with the majority of our patients within that 60 days. But if you look at the right bars, we had clearly some outliers. Greater than 100 days to me is just not acceptable. So we made a focus, at least as part of this study, to eliminate those outliers. And then we wanted to move this bar from 70% of our patients within 60 days to perhaps 80% of our patients less than 60 days, or 90% of our patients less than 60 days. And of course, the implication would be that the median time would also then shift towards the left as well. So this is where we were as a baseline. Next slide, post-QA, if you look at where we are now, and again, this is at all the hospitals where the surgery's not done, not just the Outer Banks Hospital. We're, go ahead and push that next little button, Kathy. The next, basically, this shows that we're 71% now, so I don't really consider that a significant improvement. But if you look at the right part of this graph, we've eliminated those outliers greater than 100 days, right? So that's, to me, that's huge. By tracking these patients prospectively and focusing on this, we've eliminated the people that have really fallen through the cracks. And I'd like to, of course, see that metric move further to the left. So when you look at when the surgery is done at our hospital, which is something we totally can control, the next slide will show you that. Hopefully, yep, we eliminated the outliers there. So go ahead and push one more button. You'll see that now 90% of our patients are less than 60 days when their care is done at our locally accredited hospital. So this is huge. And again, no outliers. And almost all of our patients now are receiving their timeliness to surgery in the appropriate goal for us, which is less than 60 days. All right, next slide. So from the patient-reported outcomes, 98% of our patients reported that the discussions regarding the role for all of the various providers when it was done up front was helpful in their decision-making and also helped them understand the timeliness of their journey through cancer care. Next slide. And in conclusion, our quality initiative resulted in improvements in the metrics that we are after, that I think we're all after with PROMPT. When surgery is done locally, the majority, over 90%, were done within 60 days, which was our goal. And again, we removed the outliers. And we improved all the other metrics as well, although we certainly have a long way to go to be on par with the larger breast programs. And I thank you. I think that's my last slide. Yep.
Okay, great. Thank you. So I had a question for you, Charles. You said you removed the outliers. How did you handle those outliers?
So, you know, it's interesting. When we looked at that data back in 2019 and 2020 and 2021, we've just found that a lot of patients were sort of hanging out there waiting for surgery for various reasons. It might be cardiac clearance. It might be they were on blood thinners. We had a couple of nursing home patients. We started tracking all of our patients prospectively with PROMPT, and so we kept a spreadsheet of every patient diagnosed with breast cancer in 2023. And we would look at the timeliness at each meeting biweekly. So if a patient's had surgery, we check them off the list. If a patient still has a pending surgery, we would talk about it as a group and say, you know, how come this patient isn't scheduled for surgery yet? What's the delay? And by having those discussions with the team, we found that we were able to eliminate those outliers.
Okay. Do you know kind of what the main reasons were that they weren't having surgery, or was it just kind of a hodgepodge of things?
It was a hodgepodge. I think it was a small number of people who were either in nursing long-term care facilities who were just kind of out there and holding, and not a lot of push to get them plugged into the surgeon. Some patients with blood thinners that delayed the workup and so forth. But yeah, it was a hodgepodge. Okay. I wouldn't say it was a systematic issue at all. But we did want to eliminate those outliers just as a process, because we felt like that was an easy catch for us.
Yeah. Okay. Thank you very much. That was great.
Thank you.
So we can go to now asking questions.
You came in, so I can read them out.
Yes, because I don't have any access to them. So I'll let you go ahead and read them to me, Sandra.
Sure. The first one is, will there be another nationwide collaborative QI project for 2024?
So I know the COC is lung cancer, which is not going to apply to us, obviously. Breaking Barriers is still going on in 2024. Dr. Shelton's part of that QI collaborative, but right now the NAPBC does not have any QI collaboratives for 2024, but we will be working over 2024, so we'll launch probably one in 2025. So talking about launch.
Thank you, Dr. Yao. The next question is, this person wants to know whether we sent the Salesforce login information.
You should have all gotten an email from Salesforce so that you could log in to their platform. I don't know if Riley is on the line or not, but I know that I was told that was all sent out, so it should have come to you. But we can double check that.
Thank you, Dr. Yao. The next study is, I was told that we could use the prompt study for COC if we didn't get credit for it in 2023 with NAPBC.
Okay, I was under the understanding that prompt was really just counting for NAPBC and not counting for COC as a QI project. So that was my understanding. And somebody might be asking, I think somebody had asked me in the past about whether prompt could count for some other elements of COC and other standards. And maybe that's where this question comes from, but I would have to dig back into my notes to find out what that was specifically. But for QI projects, prompt will just be counting for NAPBC.
Thank you, Dr. Yao. The next question is, can the facility that changed anti-coag protocol share more details on the change and if they experience any adverse events?
Yes, I think maybe at the ACS Cancer Conference, we could talk a little bit about that during the session. And then if that facility is able to share some details about their anticoagulation protocol, we could include that in the toolkit that we will be issuing. So that would be great. I think there's a question here about, that doesn't have really anything to do with prompt, but it's asking about the new standards. And we just went through a site reviewer training. We have a couple little small edits that we're doing with the standards, incorporating feedback from our 4 pilot site reviews that we just finished. So those new, most updated standards will be available for everybody, probably not until December, which is actually next month. So they will be available, and there will be a FAQ document that will provide some clarification, answer some of the commonly asked questions as well.
Thank you. The next question is, your slide says prompt can only be used for NAPBC compliance, not COC. Please confirm, as stated in earlier webinars, that improving timeliness to neoadjuvant chemo can be used as a cancer program goal for COC standard 7.4 compliance.
So this might get back to what I was referring to, that prompt cannot be used as a COC-QI project, but it could be used as a cancer program goal. So that's 2 different things. In NAPBC, we just have QI projects. We don't have a cancer program goal like they do in COC. So that's where the difference is. But I'm fine with it being used as a cancer program goal for COC.
Thank you, Dr. Yao. Next question just is asking how soon these slides will be available for them to review. I'm not sure what slides, maybe the presentation?
The presentation that I did today, I will send that to ASA right after this webinar so they can post it on the NAPBC portal. And we will post it on our website and on the Salesforce platform. We can also email it to everybody. And so maybe give us 24 hours just to get all of that done.
Thank you, Dr. Yao. Next question wants to know who can they email if they don't have the Salesforce login. That's brp@northshore.org. Now, if Asa could write it into the group chat, or maybe I can do it. I'll figure that out. It's brp@northshore.org. If you attended this conference, you got an email from Chantal with that email also.
I'm going to let you do that, Sandra, because I don't want to misspell the email address. So thanks so much for that.
Sure. Okay.
I see a question here during the presentation. Thought she said there will be a prompt for 20. Oh, so what I was saying in the presentation is that if you want to do another prompt QI project, let's just say you decided you were going to focus on screening to diagnostic mammogram for 2023, but in 2024 you want to look at biopsy to neoadjuvant therapy. You could do that. It would have to be a brand new project, new problem statement, new aim, all of that would have to be new. So you can do that in 2024. But I think when somebody asked me about national quality collaboratives for 2024, I think they were asking about new ones, different than prompt. And right now for the NAPBC, we do not have any new ones for 2024, but there will be one for 2025.
Okay. It looks like Chantal is answering some of them, so I'll go to the next one. If you have not received an email from Salesforce, we will look into that and resend them if we can. Someone says, thank you for presenting, Dr. Shelton. And I think the other questions have been answered. Will Dr. Shelton's presentation also be available?
Yes, we can make that, if that's okay with you, Dr. Shelton.
Of course, absolutely.
Okay, we can make that available as well.
Okay.
So
Will there be webinars afterwards for those of us that cannot attend?
I think this is a question pertaining to the ACS Cancer Conference. I think the same person had stated that their facility won't send them to the ACS Cancer Conference in Austin, Texas. Is there a way to get the information so I know how to proceed with the standards? So there will be a NAPBC standard workshop at the ACS Cancer Conference, and that is going to be on February 22nd in the morning. Is that correct, Asa?
Yes, that's correct. It's a half-day conference. It's an in-person conference only, so there's no virtual option. You can't dial in. We just can't offer it that way. I know that the Education Committee is considering offering additional content via webinars on the new standards, but they haven't developed all of those plans yet because the standards themselves aren't really available yet. So watch for more information, probably after the first of the year.
Yeah, there'll be a number of webinars, FAQ documents, lots of things about the new standards, and I think a lot of opportunity to learn about them without having to go to the meeting in Austin, Texas. So if we need to finish our project into 2024, it still counts for 2023 as long as we document in the minutes the results. Yes, correct. Okay, Sandra, do you see any other questions?
I don't. They've been all answered.
All right. Again, if you think of questions later this afternoon, tomorrow, please email us at brp@northshore.org. We will be having a webinar in December 11th. I've not scheduled technically any webinars going to 2024, but I think we probably will need a couple in 2024 just to wrap up things. So we will get that schedule out, and appreciate all of you participating in prompt, and any issues or concerns, please let us know. I'm happy to review anybody's template if you would like me to make sure that you're on the right track. I've already done that with a couple centers, and I'm happy to do that for anybody that would like me to review their template. So thank you very much for participating in prompts. Have a good day.
Thank you. Bye, everyone.
Thank you. Bye-bye.